Hi, Julie.
Hello, Rahul. How are you?
Hi, Julie.
How's everything?
Good.
Hang on, I'll make you a co-host again, okay?
Yeah, I'll join in through my phone as well and then start adding.
Well, are you on multiple devices, are you?
Yeah, to add, I'll just keep another device.
You are very greedy. Okay, so SUDHIN is awake, thank goodness. I thought I got the time zone wrong. I did, I think. Oh, that's SUDHIN. Good morning. Hang on. I'll ask him to unmute. Hey, good morning, SUDHIN. How are you?
Good. Hi, Julie. How are you?
Thank you so much for joining and sharing this with us. It's so exciting.
Thanks for the invite.
Will do. Hang on, everyone's jumping in. They're all like pouring in. So I will make you a co-host. Geez, what's happening here?
Is it
Rahul, can you make him a co-host?
Yes,
Yes, I can.
Okay, make co-host. Okay. All right.
But
So then have you got co-host access now?
I think so. Let me try.
Okay.
Let's try and share my screen.
Yay. Looking good. Lovely.
Good.
Okay. And
So you're starting in 10 minutes, right?
oh yeah. Chill, man. Chill. How's weather in London?
Good. Yeah, well, the last days have been quite hot last few days.
Like
So
what is hot?
now it's going to rain again.
How hot is hot?
How hot is hot? It's like 30 degrees.
Oh, it's all right.
Yeah.
You people are weak. Weak.
Yes.
Hang on. This is So what we'll do today is we'll pass you the baton. I'll just introduce you in the beginning and just say who you are. We'll invite the people to put in their questions on the chat page. Is that okay?
Sure.
So no one bothers you? Yeah, And then you choose what to answer at the end.
Okay, fine.
So Rahul, our fellow, is also a co-host. So if you have any drama, just scream at Rahul. He's very technically proficient.
Good.
Okay. Do you want to stop sharing your screen now? And I'll just bring up I'll just bring up my screen when you're ready to start. It will just introduce you and just some housekeeping rules.
Good.
So I will spend my time muting everyone. Rahul's very quick. He's admitting everyone.
Can you all see my screen? Julie, can you see the screen?
Yes, all good. Thank you.
Yeah, good. So I thought I'll talk about three different aspects of mild encephalopathy. One is, and the most important part, is clinical diagnosis. How do you do a good neuro exam to make a diagnosis of mild encephalopathy? And I will show you some videos as well and ask you to score. Just because this talk is on mild encephalopathy, it doesn't mean the video I'm going to show is of a baby with mild encephalopathy. So do the scoring as you deem fit. And then we'll talk a bit about short and long-term outcomes of the mild encephalopathy and some of the ongoing studies that's going on. Now, this the original SUDHIN study, it just stood the test of the time, and it just amazes me how robust it has been. It was first reported in 1976 using a variety of neurological aspects, examination of encephalopathic babies. That includes EEG as well. But one big issue with the original SUDHIN staging is that it's a retrospective diagnosis. You do it at around 24 hours of age or later, depending on how the baby progressed in the first few hours and days after birth, which was fine in the pre-cooling era. But now we need to make a diagnosis within 6 hours of birth, which is more challenging. Now, if we use the original SUDHIN staging, this is what we all learned in the textbooks. Babies with mild encephalopathy do invariably well during infancy and later childhood. With moderate, you got 20–80% chance, and severe, it's pretty poor. But we know this is not completely true, especially for moderate. It's much more of a mixed bag. And even with those mild, so if you look at the original papers, or the landmark papers from Charlie Robertson, there is in fact a mild reduction in the cognitive score just because it was not, but it was not statistically significant. And the teaching went on to say mild babies with mild encephalopathy are very similar to their peers. But anyway, now the issue we have is classifying these babies, identifying these babies within 6 hours of birth, which is pretty challenging. It's never going to be as good as the original SUDHIN staging, and there are some difficulties. But SUDHIN and her NICHT NRN colleagues have spent a lot of time on this and devised this modified SUDHIN score. It has been extensively validated in a number of high-profile publications from their group and also from our group, showing how robust that scoring system is. It's never going to be 100% accurate, but it's as good as we can get. In fact, I would like to call this as Shankaran score, but I'm sure Sita won't agree. The teaching and certification slides for this score are freely available on the NRN website. So there's a link here. If you click on that, you can go to the training that NICHT does for the scoring. Now, we tested the accuracy of the NICHT scoring in a large prospective study called MARBLE, involving around 220 babies with encephalopathy in the UK and also in US. And the neuro exam has got a similar accuracy. So under the red box, you can see the prognostic accuracy of the neuro exam, which is pretty similar to what we have with an AEG. Just try to minimize. Yeah. So the area under the curve is 0.72 for the neuro exam, and very similar for the amplitude integrated EEG performed within 6 hours of age. Now, the examination has 6 different components. First is the level of consciousness, and the most important one is actually the level of consciousness. You classify that as mild, moderate, or severe. And the way you do, the way you stage the level of consciousness is not just by looking at the baby, but you need to give a gentle stimuli and then look at the response. If the baby has got mild encephalopathy, the threshold for that response is very low. The moment you touch the baby will show some response. And in moderate, it's delayed, and that's called lethargy. And if in severe, it's absent. The other 5 criteria are the spontaneous activity, posture, tone, and reflexes and autonomic system. So what I will show now is a video that takes you through the examination. You can just watch this video. It's about a minute or two.
Welcome to COMET, Cooling in Mild
So this was made by
Encephalopathy
one of our
Trial.
fellows for the COMET
In
study.
this video, we're going to look at the
But
neurological
it will
assessment
just take you through the
used to
different
assess
components of the
eligibility.
exam.
For an infant to be eligible for inclusion into COMET, there needs to be evidence of mild neonatal encephalopathy on the NICHD neurological examination that has been performed between 1 and 6 hours of age. There are 6 domains that we assess in this examination, of which at least 2 need to be under the mild encephalopathy criteria for the baby to be eligible. The neurological examination can be split into 2 sections. Firstly, assessment by observation, and then assessment by examination. By looking at the infant at rest, we can assess their level of consciousness, whether the infant is alert and responsive, or is hyper-alert, has a stare, jitteriness, a high-pitched cry, or an exaggerated response to minimal stimulation, or is lethargic, or in a stupor. We can then assess spontaneous activity. Is the infant moving normally, or is it decreased with or without periods of excessive activity? Is it globally decreased, or is there no activity at all? Is the infant's posture flexed when at rest? Is there mild flexion at the fingers or wrists? Is there strong distal flexion and complete extension? Or is there intermittent decerebration? We can then assess the autonomic nervous system, looking at the trend of the heart rate in the preceding hour. Is it normal, or is there tachycardia, bradycardia, or a variable heart rate? Similarly, we can assess the respiration. Is the infant breathing normally, or is there hyperventilation, periodic breathing, or is the infant having apneas, or are they ventilated? We now move on to physically examine the infant. Firstly, we assess the tone. Is there strong flexor tone in all extremities? Is the tone increased peripherally? Is the tone hypotonic or hypertonic? Or is the infant flaccid or rigid? We can then assess the pupils. Are they of normal size? Or are they dilated, mydriasis? Or are they constricted, miosis? Or are they deviated or non-reactive? We finally assess the reflexes. Firstly, the suck. Is it easy to elicit? Is it weak? Or is the infant biting? Or is it absent? We then assess the morrow. Is it easy to elicit? Or is there a low threshold to elicit the morrow? Is it incomplete? Or is it absent? Once you have completed this assessment, you can then score the infant. There are 6 domains. Remember, the reflex and autonomic nervous system categories only contribute 1 point each, a worse score out of that assessment. To be eligible for COMET, there must be mild HAE or higher in at least 2 of the 6 domains. If there are 3 or more where the infant scores either moderate or severe, then this infant has moderate or severe HIE and is not eligible for COMET.
Thank you. So that's NICHD neuro exam, and that baby was clearly normal. Now, this is the criteria that was used in the TOBI trial. So in the TOBI trial, you might know this is a large Coolin trial led by investigators at Imperial College London, recruiting babies from the UK and some centers in Europe. The key difference between the NICHD trial led by Sita Shankaran and the TOBI trial was that the neuro exam was not structured in the TOBI trial, but instead amplitude integrated EEG was used. So in addition to the neuro exam, the babies had to have at least moderate to severe abnormality on an amplitude integrated EEG within 6 hours of birth. So that was the key difference in the criteria. Now, both these trials achieved managed to pick up the babies at the highest risk of adverse outcomes. So if you look at the control event rates in the NICHD and TOBI trial, both are extremely high. It's a bit higher in the NICHD trial at 62%, because the primary outcome was death, moderate or severe disability. And in the TOBI trial, it was 53% as adverse outcome was death or severe disability. But the neuro exam had a similar pickup rate as the amplitude integrated EEG. But here we are talking about a very structured and certified way of neurological examination. If you don't do it that way, then it won't be that accurate. Now, recently, BAPM, or the British Association of Perinatal Medicine, has developed a guideline, updated the cooling guidelines, which has got a similar issue, what we faced in the UK during the post-TOBI period. Because when we started using cooling as extended clinical care in the UK, in the early phases, not everybody had amplitude integrated EEG. So this recommendation was made that if you don't have AEG available, that's fine. As long as you think the baby has got moderate or severe encephalopathy or neuroexam, you can go ahead. But there is conversely, there is an issue with the statement that if you have a normal EEG, it's very unlikely that this baby has got moderate or severe encephalopathy. But often people interpret it in that way and started using a cooling criteria without including AEG, just by doing the neuro exam in the TOBI neuro exam. If you look at the key difference in the TOBI neuro exam and the NICHD examination, in the TOBI exam, all you need is some evidence of altered sensorium and one of those criteria, one of the neurological abnormalities. In the NICHD, this is much more structured, like I said, and you need at least 3 criteria to qualify for cooling. So at least 3 criteria in moderate or severe to qualify for cooling. Now, when CFM, if it is done within 6 hours of birth, it doesn't have a good specificity that if CFM is abnormal, you can't say that this baby is going to have an abnormality later on. But if the CFM is normal, it is very likely the outcome of this baby is good, and this baby do not have moderate or severe encephalopathy. Now, the second issue with the BAPM guideline is that it says it has to be done by a trained and competent examiner in the neurological examination. But at least in the UK, our neurological training program does not include training in in neuro exam of these babies, and often it is not done in a very systematic way. Okay, now I'm going to share the clinical details of a baby, and we'll ask you to score this baby based on the SCHD examination. So this was a baby who was born at Queen Charlotte's Hospital, one of our hospitals at Imperial College London. Born to 38-year-old primary gravida, normal pregnancy. Mom had PET, born by vaginal delivery, and the cord pH was 6.9. Baby was ethnic at birth, but started crying soon after with stimulation. Baby was initially kept in the postnatal ward with mom, but then was admitted to an ICU because of low sugars. The neuro exam was performed after correcting the blood sugars, and I will show you a video now. So if you can go on to the link that you have, the red cap link, and ideally on your mobile phone, and start scoring while I show you the video, that will be great. So you can go through the various components. So look at how baby is reacting when I give a stimulus. Look at the sensorium, spontaneous movements, posture of the baby, whether the baby is flexed, how the fingers are. I know you can't make an assessment, a good assessment of the tone, but do you make a guess? Just pause for a second while I take the video. Okay, so that's the video. Let's see. Sorry. Now, if we can score on the link. Okay, I'll just give you 30 more seconds. I'll just run the video again. So while we are doing the score, you can watch it. Getting all these moments. 16 people have done so far. I just gave some more time. Thirty-five people are completed now. Pause for a second while I take the people down. Okay, let me show you the results now. Okay, I hope you can see my screen. Let me look at the final staging first. So most of you have said this baby has got mild encephalopathy. So 10 of you said a baby has got mild encephalopathy, 8 moderate, and 1 severe, and 1 has said no any. Okay. Now you would have got an automated feedback from RedCap regarding the actual the correct scoring. But let me, so this is a baby with classical mild encephalopathy. The key thing you would notice is when you examine for the level of sensorium, the moment you touch this baby has got response. So the threshold for response is very low. This is very different to a lethargic baby in moderate encephalopathy. And this is the most commonest mistake people do when doing a neuro exam. Because this baby is not moving much, that doesn't mean the baby is lethargic. So that's a different category under spontaneous activity. This baby is definitely not moving much like a normal baby. But the response to the baby, to the stimulus is actually there. The moment you touch the baby is quite jittery. Baby has got some response. So the level of sensorium should be mild. Spontaneous activity, I don't mind whether you put in as mild decrease or severely decrease. So it could be either moderate or mild. Often, when there is a confusion between in which one to allocate, you go by the level of sensorium. The posture again, baby has got a very good flexure tone. So as you get more and more brain injury, the babies tend to extend the limbs. So hand will go straight, and so will be the legs. So babies lose the fetal position as you get more and more brain injury. The tone you can't assess on a video, but it was increased in this case. Suck was quite weak, but it was present. It was not completely absent. And yeah, it was not normal. Moro, the threshold for Moro was very low when most of you got it right. The moment you touch the baby has got a Moro. So definition by definition, if it is 3 millimeters in light, that is mild encephalopathy. So that's mydriasis and that's mild HI. Heart rate you cannot really use when babies are undergoing cooling therapy. So that need to be ignored in babies undergoing cooling therapy. And the respiration was, I think it was normal on the rate. So like I said, overall staging it was mild encephalopathy. Okay. Fine. Now this baby had a normal CFM. So this was a CFM. It's not normal because there is loss of sleep wave cycling, and that's the typical age appearance of a baby with mild encephalopathy. Now, what do we do with these babies? So, in this baby, we had started coma trial at that time, and this baby was randomized to 48 hours of cooling. This baby might have missed cooling therapy because the baby was in the postnatal ward earlier on. And so initially people were querying whether we should cool this baby or not, but baby was randomized to 48 hours of cooling. And then baby developed seizures at 7 hours of age. And the people were really happy that we did start cooling within 6 hours. And the clinician decided to increase the cooling duration to 72 hours as a part of the standard clinical care. And then we did an MRI scan at 1 week of age, which showed a small parenchymal bleed, and there was absolutely no evidence of HI. So now we can't be really certain whether cooling did any benefit or harm to this baby. This baby is still under follow-up and is doing very well so far. Now, the key message from this part is that you need to do a structured neuro exam, and that's not easy. It's often, it needs a lot of practice, a lot of, so when we do the actual training, there are at least a couple of joint examination that you need to do in person with the certified examiner to get a good concordance. But that is the best way we have to stage encephalopathy, especially within 6 hours of birth. It's never going to be 100% accurate, but that's the best we have. And if you have a normal EEG within 6 hours, it's very unlikely that this baby has got moderate or severe encephalopathy, and maybe a useful way to exclude infants who need cooling therapy. Now, in the second part, I'll discuss the outcomes after mild encephalopathy. But clearly, this would depend upon how we are defining mild encephalopathy in the first place. So there are a number of studies which have shown that babies with mild encephalopathy do have a variety of short-term adverse outcomes, especially if you're diagnosing mild encephalopathy within 6 hours of birth. These babies, a small proportion of these babies will develop seizures later on after 6 hours of age. And then if you hadn't started cooling, you feel like kicking yourself. So about 5 to 10% of the infants will develop seizures after 6 hours of age. So this study from Tara found 8% of the babies had seizures between 12 to 40 hours of age, and of which one baby had basal ganglia injury on MRI scan. There was no long-term follow-up in the studies, but generally basal ganglia injuries on MRI, as you know, are associated with adverse outcomes. Unfortunately, one of these babies died. That particular baby did not have an MRI scan, but when the investigators went back and looked at the records, that baby did have a abnormal neuroexam showing moderate encephalopathy at 3 hours of age. Now, the second study led by from Pierre Wintermar's group from Montreal. So they looked at the injury on MR imaging in babies with untreated mild encephalopathy and also those who were cooled. So 40% of the infants who were untreated or uncooled had some abnormality on MR imaging, and as opposed to 31% who were not cooled. And again, one baby with mild encephalopathy worsened after 6 hours of age and unfortunately died. Similar study from Terry in this group in Boston, almost half of the babies, cool babies, these are cool babies with mild encephalopathy. In Boston, they routinely cool all babies with a mild encephalopathy. Half of them had some abnormality on MR imaging. Now, Deirdre Murray's group from Ireland has been doing a lot of long-term follow-up studies on mild encephalopathy. So their first study was on 22 babies with mild encephalopathy. They used the original SANA staging at 24 hours of age to classify mild encephalopathy. And then they followed these infants up to 5 years of age and compared their IQ, full-scale IQ, with healthy control peers. What she found was that there was a significant reduction in the full-scale IQ when compared with healthy peers. And the IQ of babies with mild encephalopathy was more or less similar to those ones with moderate encephalopathy. So here you can see the actual IQ values. So you know the average IQ is 100, and it will be to standard deviation will be 85 to 115. So when you look at the absolute IQ values, it doesn't look too bad in mild encephalopathy, but they were significantly lower when you compare with healthy control babies. And these babies, many of them had a full montage EEG, not amplitude integrated EEG, but full montage EEG at 6 hours of age. And then most of these babies had some abnormality on that EEG. So these are the different, some kind of mild asymmetries and discontinued activity on the full montage EEG. But none of these infants had moderate or severe disability later on. A more recent study from the same group in collaboration with few other centers in Europe. So they followed up 55 babies up to 2 years of age and then did a Bailey 3 assessment and compared it with 152 healthy PAs. So this histogram shows the cognitive scores of the healthy babies. So on the left side is the healthy babies, and on the middle one is the cognitive score histogram of the babies with mild encephalopathy. So when I superimpose these two, you can see a shift in the cognitive score towards the lower side in the babies with mild encephalopathy. So there is a mean difference of 6, a reduction of 6 points in the cognitive score when you have mild encephalopathy as opposed to healthy control babies. There was no significant difference in the language and motor scores. Now, depending upon how you define disability, if you define disability in the similar way of the Coolin trials, only 2% had any disability. But if you define disability as mild, any cognitive score on Bailey as less than 85 but more than 70, that was present in 11% of the healthy PAs and 22% of the babies with mild encephalopathy. Now, this is the largest study, prospective study so far on babies with mild encephalopathy who are not cooled. So this is a multi-center study involving several centers in the US, and we also participated in the study. So they studied 62 babies with mild encephalopathy who are not cooled. And these babies had the same structured neurological examination developed by the NICHD and RM group, and then were followed up till 2 years of age. Adverse outcome was seen in all the 63 infants, 16% had adverse outcomes, of which 3 had severe adverse outcome and 4 had mild adverse outcomes. So these are the details of the infants who had adverse outcomes. So, but all these infants had at least 2 abnormalities on the neuro exam, which was done within 6 hours of birth. And you can see, these 3 infants had a severe disability with very low Bailey scores on all the three domains, and one child had cerebral palsy. Now, so it looks like at least 20% of the untreated or non-cooled babies with mild encephalopathy will have some cognitive impairment later on when you compare with healthy PAs. But the problem is that when you diagnose any, there's always a chance that a small proportion of these infants will then progress, will then develop seizures after 6 months of age, and then progress on to more moderate or severe encephalopathy by 24 hours. And unfortunately, there is this very small risk of mortality in that group. Okay. Now, third part of my talk is about use of cooling for babies with mild encephalopathy and challenges in doing these cooling trials. Now, there is some preclinical data suggesting if you cool infants, mice model of mild encephalopathy, cooling can completely abolish the brain injury, the hypoxic brain injury. So even a short duration of cooling, 3.5 hours of cooling, completely prevented the hippocampal injury in this mice model. Now, when you convert 3.5 hours into hours in babies, I don't know, how that corresponds, but it looks like you probably don't need a full 72 hours of cooling to get neuroprotection in babies with mild encephalopathy. Conversely, if you cool babies without brain injury, it is also possible that you may induce some brain injury. You may induce some apoptosis. Again, it's difficult to tease out the effects of sedation and other analgesia from the hypoxic injury, but that risk is always there. So we should not cool babies with perinatal anesthesia who do not have any encephalopathy, at least for now. Now, this is a systematic review we did on all the studies who kind of accidentally recruited babies with mild encephalopathy when they did cooling trials. So when we picked up these babies from the cooling trials, we found that there was an adverse control event rate, adverse outcome of death, moderate or severe disability in 21% of the non-cooled ones and similar percentage of the usual care infants. And cooling made no difference. But this is a surprisingly high incidence of adverse outcome, high incidence of death, moderate or severe disability. And this may be related to how a mild encephalopathy was defined in these trials, and none of these trials actually had a structured way of defining mild encephalopathy, and these infants maybe actually had more severe brain injury than what we now consider as mild encephalopathy. Now, we also looked at a small cohort of infants where cooling therapy was started, but was discontinued within 24 hours of starting because the baby rapidly improved, and the clinician thought that baby did not require the cooling therapy. But many of those infants, at least half of them, had some persistent injury on MRI scan. So probably a cooling duration of less than 24 hours may not provide you with adequate neuroprotection. We also did a survey. One of our fellows, Vania Oliveira, did a survey looking at cooling practices of mild encephalopathy in the UK. And most of them, 75% of the centers said they routinely cool babies with mild encephalopathy, and 25% were not cooling. This was a few years back now. I'm sure if you repeat this survey, most of the centers would be cooling. Now, the reason why the people who cool said they cool is because they thought babies with mild encephalopathy had high risk of adverse outcome, and cooling was very safe. And they were quite worried about the implications, medical legal implications and litigation, if in case baby develops seizures later on and you miss the boat for the winter period for cooling. And they also felt that it is very difficult to grade encephalopathy within 6 hours of birth, so it's better to cool everyone. And of course, some babies may progress to moderate. And the people who said they don't offer cooling had exactly opposite views. They thought cooling did have side effects. Mild encephalopathy generally do very well, and there is no evidence to support cooling in this group. In the UK, at least, the cooling therapy offered to these infants varied quite a bit. Most of them did start within 6 hours, but many centers started cooling a bit later, up to 12 hours of age, and there is very minimal evidence to support this practice. Now, some of them did discontinue cooling earlier on if there is clinical improvement, and many people use sedation alongside cooling. And most of them did heavily sedate these infants with morphine and other drugs. Now, we also looked at a non-randomized cohort of babies with mild encephalopathy who were cooled and compared to them who are not cooled. So we had 15 babies with mild encephalopathy who are not cooled, and then we compared this with 32 babies who were cooled within a number of centers in the UK. So the group was, of course, this was not a randomized controlled trial, but the group was pretty well matched with most of the baseline features, except the cooled ones was marginally more sicker than non-cooled ones. They had worse UPCA scores at 10 minutes of age. Now, then of the non-cool ones, some of them, 27%, the numbers are very small, 4 out of 15, did develop seizures after 6 hours of age, which was a bit worrying. And if you also look at the mean hospital stay, so it was 5.5 days in the non-cooled ones and 8 days in the cooled ones. So cooling does increase your hospital stay, but babies with mild encephalopathy are not the babies who will get discharged within hours or the next day after birth. They usually have some difficulties with feeding and are in hospital for a couple of days. We then looked at their injury on the conventional MRI and also the MR spectroscopy markers. So what we found was that there was a trend towards better MR spectroscopy markers in all the ones we looked at, in the ones who are cooled. So in this graph, what you're seeing is the cooled babies are shown with blue dots, and the non-cooled ones are in the red ones. Orange ones are the ones who are cooled for less than 24 hours, which we think were not effective. So overall, there was a trend towards a better MR spectroscopy biomarkers in the ones who were cooled. We also looked at their Bailey 3 cognitive linkage and motor scores, and there was no significant difference, although there's probably a tinge of a trend towards better outcomes in the with cooling, higher scores with cooling. But certainly it was not statistically significant. Now, that's when we decided to do the COMET trial. The COMET trial stands for Cooling in Mild Encephalopathy. So we are trying to ask two different questions in the COMET trial. The first one is about, that's cohort 1, that if you offer cooling to these babies, full 72 hours of cooling within 6 hours of birth, as compared to usual care, does that improve outcomes? So 60 babies are being randomized to no cooling or usual care, or cooling for 72 hours within 6 hours of birth. And then the outcomes you are looking at, the primary outcome we are looking at is thalamic NA at 2 weeks. And we also look at the mean cognitive scores at 2 years of age. Now, in the second cohort, we are looking at babies who are already undergoing cooling therapy as part of their standard care. So most of the babies who come to us and to many centers in the UK with mild encephalopathy are already receiving cooling therapy. So we approach these parents at around 48 hours of age and then randomize them to rewarming at 48 hours as opposed to the conventional 72 hours. So these are the two different cohorts we are looking in the cohort study. In the second cohort, we are randomizing 80 babies into either rewarming at 48 hours or rewarming at the conventional 72 hours. And the outcome assessments are same for both. Now, I'll tell you why we decided to go for thalamic NIA and for MR biomarkers for that matter. So if you do a clinical trial using a traditional clinical outcome measure on Bailey or whatever neurodevelopmental score you want to use, and use that as an categorical adverse outcome like moderate or severe disability, you need a massive sample size. So the sample size in the NICHD trial was just under 200, and they had an event rate of more than 62%. So your sample size is very closely related to the event rates you're looking at. The TOBI trial, although had much bigger numbers, 320 babies, it was underpowered compared to the NICHD trial because the event rate was lower. The control event rates or the incidence of the adverse outcome in the usual care group was only just about 50% in the TOBI trial. Now, in mild encephalopathy, we are talking about event rates of less than 20%. So that becomes near impossible to do using a categorical outcome measure. We can use mean cognitive scores as an outcome measure. That still requires a lot of babies, and most funding bodies don't like to do that or like to fund studies looking at just the mean values of these kind of scores. An alternative approach is using MR biomarkers. So you can either look at conventional MR imaging and then score different areas of the brain. Often we see a lot of injury in the white matter in babies with mild encephalopathy. Or we can do spectroscopy. So what we typically do is a single voxel spectroscopy in the thalamus, and we do absolute quantification of the metabolites. So the metabolites we are most interested is NAA or N-acetyl aspartate, and that is something seen only in the neurons. And when you have injury in the neurons, the level of NAA goes down, and that corresponds with a later outcome. So when you do the fitting for NAA, it's always the total NAA we are looking at, which is a combination of NAA plus NAG, N-acetyl aspartate and glutamate. The other biomarker we can look at is diffusion tensor imaging, but standardization of DTI in multi-center situations is quite challenging. So this is the last study called MARBLE. We conducted a few years back, and we looked at the prognostic accuracy of a number of biomarkers, both clinical EEG and conventional MRI and MR spectroscopy biomarker. The most accurate one was the absolute levels of N-acetyl aspartate in the thalamus, which nearly had 100% sensitivity and 97% specificity. So this is the key biomarker we have been using since then in all of our early phase trials. There is no advantage of using lactate NAA as a biomarker as opposed to NAA. Although lactate NAA is much more easier to do compared with full quantification of NAA, the accuracy is marginally lower than NAA. Now the NAA levels, like I said, correlates very well with long-term adverse outcome at 2 years of age, and does correlate with the cognitive scores at 2 years of age. And that's the reason why we are using this as a surrogate marker for our studies. So very roughly, a millimole reduction would count around 10 points in your cognitive score when you use NAA as an outcome measure. And it does not matter where you put your voxel in. And if you put your voxel in the thalamus, it will still pick up Well, in fact, it's better to put your voxel in the thalamus than white matter because the white matter is often very noisy. And when you have your voxel in the thalamus, even in cases where there is no visible MR visible injury to the basic ganglia, you will still notice a reduction in the NAA when you have white matter injury or isolated white matter injury. So, so irrespective of the site of lesion, a thalamic voxel and measurement of NAA appears to be quite robust. So that's the biomarker, like I said, we are using in the COMET trial. So in the COMET trial, we'll end up with 3 different groups. So one is the usual care group where no cooling was done, and the other group will be the group who are cool for 48 hours, and the third group is the group who will be cool for 72 hours. And the reason why we went for that 42 hours cooling is that partly because of the preclinical data that you don't need the full 72 hours of cooling to get neuroprotection, and partly because of all the additional ventilation, sedation, and all those things that go alongside cooling. So when you cool babies with mild encephalopathy, you can see on their face they're just not happy. They're almost telling you, don't cool me, as opposed to babies with moderate or severe encephalopathy who are just not bothered. So it is possible that a shorter duration of cooling may be neuroprotective and may be better than the full 72 hours of cooling, but that is just a speculation at the moment. And that's what we are trying to find out with the COMET trial. So COMET is a multi-center study. A number of centers in the UK, Europe, and US are participating. But the key issue is robust harmonization of the MR scanners before you do any spectroscopy measurements and using appropriate cross-platform sequences. Because if you use a sequence in Siemens scan opposed to Philips, you can get very different values of NA and other metabolites. So it's essential to use sequences that are cross-platform and will give you similar results, whichever scanner make you use. And it is also important to use the same standard post-processing methods for quantifying this. Otherwise, you will end up with different values. Now, this is the structure of this is the flow diagram of the COMET trial. So first cohort, we randomized within 6 hours of birth. And we've been finding it very difficult to recruit babies to this cohort because most of the babies do get cooled. Most of the babies with mild encephalopathy are getting cooled in the UK now. But it has been much more easier to recruit to COMET 2, where we are approaching parents between 24 to 48 hours of age, and then we rewarm either at 48 hours or at 72 hours. And the primary outcome, like I said, is a mass spectroscopy, thalamic NA done at 2 weeks of age, within 2 weeks of age. There is one more study going on, led by Sonia Banfashio from UCSF. So she is looking at cooling in 68 babies with mild encephalopathy. It's a study funded by the Thrasher. And her outcomes are clinical outcome scores at 1 year of age. There is one more study on Davy Point in mild encephalopathy, again going on in the US. And hopefully we'll have the results from all these studies in the next couple of years. It is a big challenge to do a phase 3 randomized control of mild encephalopathy, but ideally that's what that need to be done. And of course, such a study would need massive international collaborations. So to summarize, do a structured neurological examination whenever you can. A normal EEG may not help you in deciding which babies who need schooling, but if you have normal EEG, it's unlikely that babies have moderate or severe encephalopathy, and it's unlikely that these babies will fit the traditional criteria of cooling. Mild encephalopathy is clearly associated with slightly lower cognitive scores in later life when compared to healthy PAs. And although cooling is now widely practiced in the UK and around the world, I'm sure in other developed countries, it should be still continued as experimental in mild encephalopathy. And the optimal duration of cooling in mild HI is still unknown. So that's all what I wanted to say, and thank you for your attention. And I'm happy to take any questions now.
Oh, thank you, Sudhin. You have a ton of questions on the chat page. We've got like 2 minutes left.
Okay.
Maybe we could choose, and then if anyone has burning questions, you could email Sudhin privately. So Sudhin, can you see the questions on the chat page?
Yeah, reading through.
Yeah. So
the
first one, way back at 5:20 p.m. was from Kurt the Wall, who said that it's the neurological exam, which is the big thing in your assessment. Is it the same while the baby is being cooled?
Sorry, just repeat that.
He says, do you consider the neurological examination the same while a baby is being cooled as before the baby was cooled?
Yeah, it's a bit tricky. Cooling does induce some changes to the appearance, how the babies, but not too much though. Again, sedation can also affect the neuroexam, so it's difficult to we document that whether how much sedation baby has been on when doing the neuroexam. But one of the striking things I've seen is when babies are on heavy dose of anticonvulsants, often you see a discrepancy in the autonomic responses. So often they retain their suck, but the motor completely goes off. On babies on cooling, you need to make a judgment whether it's due to the cooling or due to the drugs. But that's a clinical subjective judgment.
Okay, I'll summarize John's question next. John Smythe is from our unit in the Royal. He's asked 2 questions. The first one was, Sana and his wife had only 21 babies in their study. And in their experience, mild babies do not have the exaggerated response or increased tone. Has your group thought of using the total SANET score from Charlek's analysis?
Yeah, let me share a screen. So Lena did that secondary analysis from the prime study, just looking at the total score. So let me share this one. And we looked at the same in the marble study. So within the components of the NICHD, you have different prognostic accuracies. So individually, none of them are highly accurate. When you combine all these, your accuracy is much better. So total SANET score essentially assigns an individual number. So if you're under mild, you get 1 score. Under moderate, you get 2, and severe, you get 3. And then you just add up all the scores. So that's how your total score, the maximum score you get is 18. So it can go from 1 to 18. The prognostic accuracy is very similar. In fact, it's is very similar to the NICHD examination, the total, the way we classify as mild, moderate, and severe. So it was the area under the curve was 0.63 for total SANET score and 0.72 for the NICHD examination. But it is useful when you're trying to look at babies with mild encephalopathy. For example, if you have less than 3 signs, 3 abnormal signs in the total SANET score, you're very unlikely to have an adverse outcome. So yeah, so total SANET score may be useful for the future cooling trials of mild encephalopathy, and also for monitoring these babies with HI, because often clinicians like to see a number rather than just classifying as mild, moderate, or severe. Yeah.
Okay, that's great. We might have like a couple of more questions. I'll summarize Dr. Lucy's questions from Indonesia. Basically, she asked if there was any side effects of cooling a mild baby.
It's difficult to say. I mean, we didn't see any difference in the blood biomarkers, platelets and all those things. But when you look at the face of these babies, they're just so miserable compared to the moderate and severe ones. but I don't know if that's a side effect or not. But unless you do this long-term studies, we will never know. We'll never know. This is a therapeutic creep, and this is something uh, we should have robust clinical evidence before using it as a standard of care. So whenever we go for therapeutic creep, there's always a risk, and there is no way we'll know whether we are causing more harm or benefit by cooling these babies, unless we do an RCT.
Not sure whether you can answer this in the last few minutes. SUDHIN, one of our participants from Indonesia, Dr. Rina Wati, said, what do you think of the Thompson score?
Oh, please don't. Let me just show that scoring. That's something I would say I'd strongly discourage people using. Purely because, I mean, nothing to do with Thompson. He's a wonderful person.
Wonderful.
But just that, the way Thompson score is, let me show that screen. People recommend Thompson score saying it's very easy to use. You may think it's easy to use just because there is no standardization there. But the categories you're using is a bit similar to the NICST1, and just that you're not standardizing it. But if you look at Thompson score, you can have a baby who's having seizures, but still score only 1 or even 2, and be classified as a even healthy or a mildly encephalopathic baby. So this was developed for use in African settings for people who are not clinicians. And in our experience, I not found good correlation with any of the MR injury or later outcomes. So I know it's very widely used, increasingly used, even in the UK. But I'm not a big fan of the Thompson score.
Okay, you've got a chat pane in front of you. Do you want to answer the last question before we close up? I can, the other guys can just send you their questions if you don't have time. Yeah, you've got quite a few questions there. They're pretty heavy questions. Just choose one.
What is the ideal time to do neuro exam? Yeah, I mean, I think, you don't do the neuro exam within an hour of age. Often babies will appear more obtunded at that stage. Once babies are kicking around admitted to an ICU, then do a neuro exam between 1 to 6 hours. And I would take the worst neuro exam during that period as the abnormal one.
Okay, well, so the take-home message is that you've lost equipoise in the UK for cooling mild HIE babies. Is that right? And whereas we still don't know what to do in the rest of the world.
Well, I don't know if it's just the UK, because there are similar surveys done in the US. More than 80% of the units are cooling babies with mild HIE. But the issue, Julie, I think even the people who deny they will never cool mild HIE, when you ask them to score the babies with mild HIE, they are actually misinterpreting them as moderate and cooling them. So yeah, it's actually how you define mild HIE that's the issue. So if you have
Okay,
HIE who is staying in the hospital for more than 3 or 4 days without being cooled, then I agree those people are not cooling mild HIEs. But if you think in your hospital you don't have any babies who are staying for more than 2 days who are not cooled, then it's likely that you've been cooling all babies with mild HIE.
Okay, and before we end, I see Nadia Badawi, who's the chair of the Cerebral Palsy Alliance online. I'm going to put you on the spot, Nadia. I know you joined late, but what do you think of cooling mild HIE babies?
I was there from the beginning. I heard it all.
Well, you now. Okay.
But thank you. Look, I suppose, I think we're using the term neonatal encephalopathy and HIE interchangeably. I think we need to stick to HIE as the subgroup. And actually, I suppose I would have described that baby as having moderate NE. And in fact, the baby developed seizures, thereby, I think, proving the point. So I think that discussion around mild, moderate is a long one that we need more time for.
We might have part 2.
I completely agree,
Yes.
Nadia. Thank you so much for joining in. Yeah.
Thank you